And you may resume your questioning when you're ready, Mr. Conrad.
Morning.
So I want to kind of start where we left off yesterday when we talked about your report. That's exhibit 537. Judge Manfred. Yes. Okay. I'm going to hand you with the marks. It's exhibit 537. It's a copy of your report.
Okay.
And so when we talked about your report that you created in this case a bit, but the information in your report included the pertinent medical history section, correct?
Yes.
Okay. And in there, you're quoting from Dr. Clark, the Pierce County medical examiner that did the autopsy in this case, right?
Yes.
And you said that you fundamentally agree with his assessment and the opinions detailed in his supplemental report, right?
Yes.
And so one of the things that Dr. Clark points out there as the facts that he's relying upon, those are facts that you're relying upon as well, right?
I think there are facts that that he's referring to that I also are relying on. I'm not going to limit myself entirely to what he relied on.
Understood. Fair enough. But one of the things that he's included within his report, and obviously you've now put it in your report, is that he says that upon arrival of the emergency medical personnel at the scene of Ellis's encounter with law enforcement, Ellis was face down, that he was still handcuffed and hobbled with a spit hood over his head. You see that?
Yes.
Okay. And have you come to understand that Mr. Ellis, at the time that EMS arrived, he was not face down, right?
Yes, and I testified to that yesterday.
Okay. So that's a fact that was presumed by Dr. Clark, right?
Yes.
That's not accurate.
Correct.
Okay. And then he goes on to state that an initial cardiogram, ECG, showed normal sinus rhythm. The combination of normal sinus rhythm on an ECG and a lack of corresponding pulses on physical examination is most consistent with pulseless electrical activity, PEA, right?
That's what he says, yes.
Okay. And you agree with that as well, right?
Well, not exclusively. The definition is not limited just to that description.
But what he's stating there, and what you've included in your report as well, is that the initial EKG showed normal sinus rhythm, right?
In my report, I don't say that.
Okay.
I don't say that in my report.
Well, we're reading from your report, right?
No, you're reading from Dr. Clark's supplemental report that I quoted. But my report, the part that I authored, where I talk about my analysis and opinions, I don't state that.
Okay. Well, then, you included this information because you felt it was important, right?
Yes.
Okay.
Didn't mean that I was vouching for the accuracy of every single fact element.
Okay. Because the initial electrocardiogram does not show normal sinus rhythm.
Correct.
Okay. It doesn't show sinus rhythm either.
Correct.
Okay. And do you remember in your defense interview that when we asked you about normal sinus rhythm or sinus rhythm, well, have you had an opportunity to look at the transcript of your defense interview?
Yes.
Okay. And in the defense interview, we asked you about this initial rhythm strip, right?
Yes.
The rhythm strip at 11:37, I think it's 32.
Yes.
And you initially indicated that was the PEA,
Yes.
but that's not normal sinus rhythm, right?
Correct. But it's still PEA. You don't have to have sinus rhythm to have PEA.
Okay.
As long as you have a rhythm that should produce a pulse, but you don't have a pulse, that's PEA. What he had was atrial fibrillation, which, as I mentioned several times yesterday, is totally consistent with having a normal pulse. I mentioned how I have patients who've been in atrial fibrillation for decades, and they're walking around, going to work, and having a normal pulse.
Okay. But PEA also requires it's essentially, right, you're saying it has to be an organized, so let's talk about PEA. And I didn't go to Yale, right? So I'm just trying to make sure that I'm understanding this correct. So PEA requires some organized rhythm, right?
No, you're using the word organized. I'm not sure what you mean by organized. So there isn't a requirement for organized per se. It's that there is a rhythm that can sustain a normal pulse. Obviously, it can't be something like ventricular fibrillation, which would not sustain a normal pulse. It can't be something like ventricular tachycardia with a heart rate of 280, like we showed yesterday. That won't sustain a normal pulse. But if it's atrial fibrillation or any atrial rhythm, even if it's not sinus rhythm and it's not too rapid a rate, that can sustain a normal pulse, and it should. If it's not sustaining a normal pulse, that meets the criteria for PEA, pulseless electrical activity.
Okay. Can you turn to page 4 of your report?
Yes.
And you see page 4, you have this big graph, right?
Right.
Similar to the graph that you showed the jury.
Right.
That says pulseless electrical activity, PEA.
Right.
And then you say, if no pulse with this rhythm, and you show the rhythm there.
Yes.
And then under it, you say, note that PEA can look like any rhythm, any organized electrical activity. If no pulse, it is PEA.
Yes.
Okay. So any organized electrical activity with no palpable pulse.
Right.
That's PEA.
So now let me define organized. So organized means that it is a rhythm that should produce a pulse. So we saw with atrial fibrillation from this case of Mr. Ellis that he had ventricular spikes. The ventricles were contracting or should have been able to contract given that they had a normal heart rate. So that is organized in the sense that the ventricles, which are the pumping chambers, are getting a signal that should create an ability to pump. If those ventricles are not pumping, it's electromechanical dissociation. There's still electrical activity, but the muscle is not functioning. That's PEA, and as I mentioned, PEA is classic for hypoxia-induced cardiac arrest.
Okay. And part of that analysis requires that there be no palpable pulse, right?
Yes.
Okay. And so when we asked during your defense interview, I specifically asked, when the PEA was present, you looked at the initial rhythm, right?
Yes.
And you said it's important what the initial rhythm is.
Yes.
Okay. And so that's why you pointed at that 11:37:32. And you
Right.
said that's PEA.
Yes.
Despite it being atrial fibrillation.
Correct.
And you said you know it's PEA because it's some organized rhythm that would be sustainable with life.
Yes.
And that you assumed that there was no pulse, right?
Yes.
Okay. And now you've come to find out that there was in fact a pulse at that time. Right?
Well, I haven't found that out. I've heard one opinion offered by Lieutenant Wilson during this trial, which conflicts with his interview that was obtained 2.5 years ago, and I based opinions on that, where Lieutenant Wilson said there was PEA at the time I started CPR. Those were his words in his interview a year after the incident. Now, 2.5 years after the incident, he's got a different version of events. So I was relying on the testimony that was closer to the event, where Lieutenant Wilson said at the time he started CPR, it was PEA. Those were his words. It was PEA.
So you're saying that, well, first of all, I'm going to move this strike. The last portion of that is non-responsive.
And I believe it was responsive.
Overruled. The answer stands.
Okay. So you're saying that Lieutenant Wilson is changing what he told people during an interview that you reviewed? Is that right?
I'm saying that what he said in his interview is different than what he said during this trial. I'm not using the word changing. I'm not using any assessment of motives. All I'm saying is the testimony that was available back then was his statement that the time that Mr. Ellis lost pulse, there was still electrical activity, and he called it PEA.
Okay. I'm going to show you State's Exhibit 24. Okay. This is the pre-hospital care report that you were relying upon as well, right?
Yes.
Okay. And can we publish State's Exhibit 24, please? Okay. So can we scroll to the next page? Right there. And this is information that you were relying upon during your drafting the report, right? Your report.
Yes.
Okay. And this is information that you were relying upon during the defense interview, right?
Yes.
You didn't have the life pack data at that point, right?
Correct.
Okay. And so you told us during the defense interview that at 11:37:32, right, that was PEA, right? That there was no palpable pulse.
Right.
And now you're saying that Lieutenant Wilson is changing his testimony based on what you had previously reviewed in the interview, right?
I'm going to object that misstates what Dr. said.
He's asking the doctor, is that what he just said? Overruled.
So we can look at the testimony from Lieutenant Wilson's interview, and I can show you where he said that at the time that Mr. Ellis lost pulse, there was still electrical rhythm, and it was PEA. Moreover, when we're looking at this pre-hospital care report, I'm not just confining myself to the timeline. I'm also looking at the narrative, and the narrative says something that's a bit different than what the timeline says. The narrative says sinus rhythm deteriorating into bradycardia and asystole PEA, CPR initiated.
Okay.
So I was relying on that as well.
Doctor,
Yeah.
my answer is really specific, right? So you're saying you relied on Exhibit 24, right?
Yes, the entirety of the 24, yes.
I'm sorry, what was that?
The entirety of 24, I'm sorry.
Entirety of 24. You are now saying that you believe that what Lieutenant Wilson said during his previous interview is inconsistent with what he's saying on the stand? Is that what you're saying?
Yes.
Okay. But what time does it state within Exhibit 24 that CPR was started?
2341.
And you indicated that that initial rhythm was at 11:37:32, right?
Correct.
And you said at that point he's got no pulse. That's what you said and what you assumed.
Correct.
So based on that initial assumption that you had, you were assuming that the paramedics, that the EMS, those first responders that go out every single day to try and save people's lives,
I'm going to object that this is argumentative.
Finish the question.
that they were sitting there with a man who had no pulse from 11:37:32 and didn't start CPR until 23:41?
Same objection, Your Honor.
That is argument.
Okay. So your assumption was that at 11:37:32 he had no pulse, right?
Yes.
And that they didn't start CPR until 11:41:11, right?
So I'm not making any allegations of misbehavior.
That's
Just
what-
let's make that
That's
clear.
what the
Yeah.
pre-hospital
Hold
care
on a
report says,
second.
right?
The question is, was that your assumption when you made your
Was that your assumption?
Yes.
Okay. PEA was the focus of your report, was it not?
So I talked about two types of cardiac arrest pattern, both of which are consistent with hypoxia, asystole, and PEA. Asystole, flatline, and PEA, where there's electrical rhythm but no pulse. Both are consistent with hypoxia. Both were present in this case. Both are not consistent with methamphetamine. Both are not consistent with underlying heart disease. So the report did not limit the discussion to PEA. It also talked about asystole, and there are 2 paragraphs of detailed discussion about asystole.
Well, so would you agree with me that PEA is a common rhythm that you see at end of life, right?
That's a very generic statement, so you're not giving me any kind of context or, yeah.
Let me give you a hypothetical. Say that I am shot in the chest, using blood, losing blood. It's possible for me to go into PEA at the end of my life, right?
Well, that would be actually a common cause of PEA, because hemorrhagic shock is a cause of PEA,
Right.
where there's still electrical rhythm, but the heart is not able to generate a pulse because there's no blood, because the person is bled out. So that's a whole different form of PEA. It's not what we're dealing with in this case. But yeah, of course, that could be a cause of PEA.
Okay. That the lack of circulation of blood can lead to PEA.
Yes.
Right? Okay. And you mentioned asystole, which means essentially you're flatline, right?
Yes.
But would you agree with me that in PEA cardiac arrest, you're seeing PEA prior to asystole?
Yes.
Okay. And in this case, there's no mention of any PEA prior to asystole, right?
Well, when you say there's no mention, I'm not sure
So let me,
that we can
let me
accept
rephrase
that. Yeah.
That Mr. Ellis, the testimony in this case has been that Mr. Ellis had a palpable pulse up until the point that he went asystole, right?
That's not clear to me from the testimony at all. I just mentioned that Lieutenant Wilson, in his interview back in, I think, March of 2021, said that at the time that Mr. Ellis lost pulse, there was a rhythm, and that he concluded it was PEA. He said that. He was there. He was first responder, as you said.
Then why did you point out at 11:37:32 that is where you saw PEA in your defense, right?
Because there is electrical activity.
Yep.
And there was loss of pulse. As to the exact timeline of that issue, there is some uncertainty. Mr. Wilson, in his interview, talked about the fact that actually several different people were checking the pulse, and at times they weren't necessarily checking it, that they kind of needed more people, so I think the timeline is, as is often the case when you're dealing with a crisis and an emergency and resuscitation, the timeline is often not exactly precise. It's not like a football game where you have a guy, right on top of the stopwatch and telling you exactly how many seconds left in the game.
So you're telling us that essentially you don't know when there was PEA, correct?
Well, I know there was PEA, and I know there was asystole. We can have differing versions as to exactly the timing, but if we look after CPR was started, there was resumption of atrial fibrillation, and yet there was no pulse. CPR had to be continued. That would be PEA. So whether asystole preceded PEA or PEA preceded asystole, to me is irrelevant, because they're both like Siamese twins. They're both part of the same picture. Hypoxia causing bradycardia, as described in the narrative here, then asystole and PEA. Whether it was PEA asystole or asystole PEA is irrelevant. They're all part of the same picture, hypoxia-induced cardiac arrest, and nothing else explains it. Methamphetamine would not do that. Underlying cardiac disease alone would not do that.
But you just told us, right, that in PEA cardiac arrest, you would see PEA preceding asystole, right?
Typically, that is what occurs, yes.
And now you're saying that the PEA could have come before asystole or after asystole.
What I'm saying is,
That's what you just testified to, right?
yes,
Okay. So the presumption that you initially had, right, that PEA, the initial presumption that you had based on 113732 was that PEA came before asystole, right?
so my initial presumption was based not just on,
My question is very specific. The initial presumption that you had was that PEA came at 113732 prior to asystole, right?
based on the entirety of the narrative, which included the discussion in the narrative about the sequence of events.
Okay, and including the time that they started CPR, correct?
Yes.
Okay. And now you are saying you don't know whether PEA was before or after asystole, right?
I believe that it was based on the entirety of the testimony and the fact that Lieutenant Wilson said when Mr. Ellis lost pulse that there was electrical rhythm and that therefore it was PEA. And those are his words in his interview.
You don't know whether there was PEA before asystole or after asystole now, correct?
I don't know, but based on the entirety of the evidence, I believe there was PEA before asystole, and there was PEA that continued after asystole. And again, these two processes, PEA and asystole, coexist with hypoxia-induced cardiac arrest.
Well, PEA can happen from loss of perfusion of blood, right?
That's a very broad and nonspecific term. It can be due to massive hemorrhage and loss of blood. You don't get loss of circulation alone causing PEA. It has to be under specific circumstances, which I have discussed. Hypoxia, hypovolemia, which means inadequate blood volume, high potassium levels, hypothermia. So all of those other processes are not applicable in this particular case. The only one that makes sense is hypoxia. If you have a cardiac arrest due to ventricular fibrillation from a heart problem or from methamphetamine, that isn't going to then evolve into PEA. That does not happen.
The other thing you've mentioned now is bradycardia, right?
Yes.
Bradycardia means a slow heart rhythm.
Yes.
Okay. And that's usually under 60 beats per minute, right?
Correct.
Okay. Your report doesn't mention anything about tachycardia, right?
Correct.
It doesn't mention anything about an individual going from brady to tachy and having a variable heart rate as well, right?
Correct.
And can we pull up Exhibit 2739, please? Can we scroll? So this is the initial rhythm and the life path data, right?
Yes.
Okay. Can we scroll forward, please? Go ahead, stop. Well, let's go at 11:37:40, please. Okay. So again, I didn't go to Yale. I can put a carburetor together, but let's count up how many beats per minute Mr. Ellis had. And let me know if I'm doing this correct, right? The QR complex, right? The ventricle rhythms here are beats. Is that right?
Yes.
Okay. And so we're doing it for a minute. So 60 beats, right?
Yes.
Or 60 beats per minute would be 60 to 100 would be regular, right?
That's the normal range of heart rate,
Normal
yes. Yeah.
range. 60 under would be Brady, right?
Yeah, 50 and under Brady, yes.
Okay.
Yeah.
50 and under. Let's do from 11:30. Let's do 11:37:40, right? So this is 39 and 40, right? You with me?
Yes.
Okay. We have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19. So about 19, right?
Okay.
19 beats in a 10-second period.
Right.
What does that equate to in terms of what his pulse is at that point?
114?
Okay. That's not bradycardia, right?
No. The bradycardia that we were talking about was earlier. Yeah.
Okay.
Yeah.
That's tachy, right?
Yeah, but heart rate of 114 is not something that makes it impossible to have a pulse. People will often have heart rates in that range.
Okay. Nowhere in your report do you say that a tachyrhythm would be consistent with hypoxia, right? Nowhere in your report do you state that a tachyrhythm would be consistent with hypoxia. That is the question, doctor. Go ahead, take a look at your report.
No, I hear your question. I'm letting you catch your breath. Okay, so the answer is, yeah, I agree. I didn't mention tachycardia, yeah.
You mentioned bradycardia. That's it.
Yeah, because I took that from the narrative in the pre-hospital care report.
Well, which one? Umberto's narrative or this narrative?
So in this narrative, it says,
I haven't asked a question, doctor. Thank you. Hold on.
okay, anyway, that's what I relied on because it says bradycardia on the narrative. In Mr. Ellis's narrative.
Because you didn't have the life fact data at the time, right?
Correct.
I want to ask you about the medical records that you ended up receiving, okay?
Yes.
And included medical records, ER visits from Mr. Ellis, right?
Yes.
Mental health records as well, right?
Yes.
And in there, you would agree with me that there's evidence of Mr. Ellis having respiratory issues.
Yes.
Okay. Do you know when the last time Mr. Ellis was experiencing breathing problems?
Not specifically.
Okay. Would you agree with me that it would be important to know, you can take that one, it would be important to know when he was still experiencing breathing problems in this case, right?
It would be important to know on the date of the incident, March 3rd, at the time of that this incident started, was he having respiratory problems before he was put in prone restraint? I'm not aware of any evidence indicating that he had respiratory problems before he was put in prone restraint.
Okay. And, right, because your analysis is based on the fact that you believe he was having respiratory issues, right?
I understand that he had a history in the past of asthma was described, other respiratory issues, but that seemed to have been inactive. What I'm saying is on the date of the incident, March 3rd, 2020, prior to be placed in prone restraint, there was no information indicating that Mr. Ellis had any respiratory problems.
Prior to, you mean on that day?
On the day, March 3rd, 2020.
Okay.
Right.
You would agree with me he's had many issues with breathing problems leading up to that date, though, right?
Yes.
Okay. But so back to my question. You're saying that he becomes hypoxic, right?
Yes.
And that the hypoxic condition is caused by respiratory issues, right?
Yes.
His inability to breathe.
Correct.
So you'd agree with me that it's important to know why, if he is having this inability to breathe, what's causing it, right?
Correct.
Okay. And your opinion is based on the fact that you believe that the officers and the prone restraint and how he was treated that day is what caused him to have these respiratory issues, right?
Correct.
You also believe the methamphetamine contributed to that.
Correct.
You also believe that his heart disease or cardiomyopathy contributed to that as well.
Yes.
And that's because the cardiomyopathy that he has, right, that it's makes his heart have to work harder to pump and keep up with strenuous activity. Is that fair?
Yes.
Okay. And the methamphetamine also causes the heart to become tachy, right?
Yes.
A fast heart rate.
Yes.
Okay. And that it also causes vasoconstriction as well. Would you agree with me on that?
It can. It doesn't always do that, but it can do that.
And that's that constricts the vessels of the heart, right?
It can. Yes.
And creates an inability of the heart to pump blood effectively as well, right?
It can.
Okay. So we have this combination of these things happening where you have a heart that has a difficult time pumping, right? Keeping up with demand.
In certain circumstances. We know prior to being placed in restraint, Mr. Ellis certainly had enough energy and activity to be running around, and I understand that's why there was the encounter with law enforcement and his being placed in prone restraint.
Okay. So his heart has this a difficult time keeping up with demand.
So again, prior to being put in prone restraint, there was no evidence that his heart had difficulties keeping up with demand. He was quite active. He was hyperactive. So I don't see that there was any evidence on the day of the incident that his heart was not able to keep up with demand.
Well, why do you think he was hyperactive?
Okay, I understand this encounter was because he was active and agitated and confronting law enforcement.
Okay. And so we've talked about these three factors: the condition of his heart, the methamphetamine, and then his positioning and restraint. Right?
Correct.
Okay. And you'd agree with me that we know that the methamphetamine level that he has is lethal, right? Potentially lethal.
Correct.
2,400 nanograms, right?
Yes.
2.4 milligrams per liter.
Correct.
We know that he's got cardiomyopathy, right?
Yes.
Means that he's got a heavy heart, as well as he's got thickening of his heart chambers, right?
Yes.
And then on top of that, you add obviously the strenuous activity and placement, right?
Yes.
Okay. There is no doubt, right? Well, I should say this. The medical literature is undisputed that cardiomyopathies increase someone's risk of death. Do you agree with me on that?
Yes.
Okay. There's also, the medical literature is clear that methamphetamine can also lead to your death, right?
Yes.
Especially at those types of levels, right?
Yes.
Okay. But the medical literature is disputed as to whether an individual that's placed in a prone position and restrained, whether that can actually cause death, right?
Yes.
Okay. Other thing I wanted to talk to you about was this idea of VTAC and VFib, ventricular tachycardia and ventricular fibrillation. Don't ask me how to spell it. So, you'd agree with me that if Mr. Ellis, you believe that if Mr. Ellis died of methamphetamine, you would see ventricular tachycardia or ventricular fibrillation, correct?
If methamphetamine was the sole cause of, yes, I mean, if he has methamphetamine in his system but dies because of hypoxia, then it's going to be PEA and or asystole, as we've mentioned.
Okay. And you're saying that you're not disagreeing that he does have ventricular tachycardia at one point in time, right?
Yes, that's after he received multiple doses of epinephrine. We discussed this yesterday. It's a medication used to restore function of the heart, but it's also a very powerful stimulant and can irritate the heart and cause tachycardia, arrhythmias.
Okay. It's a powerful stimulant, right?
Yes.
Methamphetamine is also a powerful stimulant, is it not?
Yes.
Okay. Methamphetamine also causes abnormal heart rhythms like ventricular tachycardia, right?
Yes, and I've acknowledged that
Okay.
multiple times. Yeah.
And you're saying that the ventricular tachycardia in this situation, you believe that it's not evidence of meth overdose because that it occurs after asystole, is that right?
It occurs after Mr. Ellis was administered several doses of intravenous epinephrine. So not only is it a powerful stimulant, it was injected right into his circulation, which is appropriate because you're trying to, save his life. But that powerful stimulant, 7 doses of that, can trigger ventricular tachycardia.
You agree with me that epinephrine is a drug that's commonly used by first responders in resuscitation efforts, right?
Yes.
Okay. And you've been in private practice since the 1980s, is that right?
Yes.
Okay. And I looked at your website. One of the things you pride yourself on is being what you call as a concierge doctor, is that right?
Yes.
Okay. And you're based out of Santa Monica.
Yes.
Your office is on Santa Monica Boulevard, is that right?
Yes.
Okay. And as a concierge doctor, you say that I'm free to spend as much time as you need, helping you understand your health conditions and treatment regimens, and putting you on a path to your best health, right?
Yes.
And as a private practice physician, the patients that you see, it's determinative of whether you can see them or not based on what type of health insurance they have, right?
Sustained.
Okay. As a private practice physician, you are treating a certain section of our economy, of our society. But it goes to how often he sees these types of issues.
Why don't you go directly to that question?
Okay, I can go directly there. I was going to block it there, but
I know.
okay. So, well, do you remember during your defense interview I asked you when was the last time that you saw a patient that was having cardiac issues related to methamphetamine? Remember that?
Yes.
Okay, and that was in 2022, right?
Right.
And you said about a year ago that you had seen it, right?
Yes.
Okay. You don't typically deal with medical emergencies as a private practice cardiologist. Is that fair?
No, it's not fair. As I said in my interview, I've had many years of experience working as an emergency room cardiologist on the panel, which includes all comers, people with and without insurance. And I told you in the interview that over those years, I specifically said 2005 to 2019, that I was seeing a methamphetamine patient in the emergency room setting approximately once a month. So I had quite an extensive experience dealing with cardiomyopathy and arrhythmias due to methamphetamine, and I mentioned that. And I said that in my current situation, I no longer go to the emergency room as a panel doctor. I only go to see my own patients. I have one patient who's a recovered methamphetamine addict and who currently is not having any cardiac symptoms at all. But I haven't, the last person that I saw with methamphetamine emergency issues was in 2021. So that's what I said in entirety. You just chose to take one little piece of that discussion.
Okay. So the last time that you've seen someone that has suffered from methamphetamine cardiac issues was in 2021?
The last time I saw a methamphetamine emergency was in 2021. I told you I have a patient who's a recovered methamphetamine addict who's still seeing me as a cardiologist. His cardiac issues are under control with medications as well as his discontinuation of methamphetamine.
Okay. So he's continued to have, or he had cardiac issues related to his methamphetamine. Is that correct?
Yes, but he's asymptomatic and his quality of life is very good.
Okay. And you agree with me, you're not currently an emergency room doctor, right?
Correct.
All right. So when you worked as a cardiologist within the emergency room, it would be an emergency room doctor that would call you down if there was a cardiac issue.
Correct.
Okay. And you're not a toxicologist either.
Correct.
You've never worked as a first responder either.
Correct.
And you're not a pulmonologist either, right?
That is correct.
And a pulmonologist is someone who specializes in the pulmonary system, right?
Correct.
The lungs and the ability to breathe is part of that.
Correct.
I don't think I have anything else to say.
Okay, redirect.
Morning, Doctor.
Morning.
I just want to follow up on a couple of things that you were asked about. First of all, let's start with Exhibit 24. If we can get that back up. And if you could highlight the narrative section. You were asked questions about the 2739, which is the life pack information, and a pulse rate of 114.
Yes.
Or thereabouts. In anywhere in Exhibit 24, does Lieutenant Wilson or Paramedic Wilson note that or say that there was any sort of a faster heart rate or variable heart rate for Mr. Ellis?
Well, he mentions the ventricular tachycardia, but that's later, after the resuscitation process, after the multiple doses of epinephrine.
Okay. And is that where he says no one run of pulseless BTAC and PFib?
Yes.
Okay. Other than that, how does he describe Mr. Wilson or Mr. Ellis's pulse during the time he was caring for him?
Sinus rhythm deteriorating into bradycardia and asystole/PEA.
And you mentioned when defense counsel counted out spikes on the life pack information, that the pulse would be about 114. Where does that fall, if you can just let us know in terms of how, is that considered particularly high or not?
It's mildly elevated heart rate. It's not anything that would cause someone to be pulseless,
So if I walked up and down the stairs a number of times, would my heart rate be 114?
at least.
And is it higher than that typically when people exercise?
Yes.
All right, you were asked yesterday about an exhibit. Well, first of all, let me back up. Yesterday, you were asked some questions about if you knew the number of officers who were present at the scene, what they were doing, those types of questions. And you asked to clarify one of your answers, and you weren't able to do that. Could you just tell the jury what you wanted to clarify with respect to that?
That's not a question.
Sustained.
Can you tell us Doctor, what were you asked to do in this case in terms of making determinations or opinions?
Same question. That's the same question, there's a word different. That's not a particular question.
It's a question. Although it's been asked already, but go ahead. There you go. That's a better objection, but I'm going to permit this anyway. Go ahead.
Yes, I was asked to offer opinion as to whether the restraining process was contributory to Mr. Ellis's cardiac arrest and subsequent death, and to address various opinions and theories regarding the cause of the cardiac arrest.
Were you asked to give any opinions with respect to each defendant's culpability or their actions?
No.
Now, you were asked yesterday about a list that we could put up on your screen, 2742. First of all, can you tell the jury what's that list entitled?
Documents primarily relied upon by Dr. Daniel Wohlgelernter.
And does that list contain all of the documents that you reviewed in preparing your opinions in this case?
No.
Why did you prepare that list?
I was asked to list the documents that I primarily relied upon, that gave me the information upon which I felt I could offer an opinion.
And what documents were important to you in reaching your opinions in this case?
So documents that described the prone restraint process and Mr. Ellis's response to that process, his comments, his statements about I can't breathe, multiple statements to that effect, comments from the officers about change in his pattern of breathing, ultimately described as agonal, agonal breathing, which is breathing that is ineffective and shallow and usually precedes cardiac arrest or death. I also felt that the documents from the pre-care hospital report, pre-hospital care report, excuse me, as we've discussed multiple times, were important, and also the autopsy information, medical examiner's report that talked about Mr. Ellis's underlying conditions, and those helped me determine what the likely cause of the cardiac arrest and death was.
Okay. Was the list that you just looked at, 2742, was that list intended to cover all documents that you reviewed in this case?
No.
You can take that down. Thank you. And you were asked some questions yesterday about whether or not Mr. Ellis had a toxic dose of methamphetamine. What does toxic mean, lethal?
No, not necessarily. They're not synonymous.
Can you
Sustain. I'm sorry, overruled. You may answer.
So toxic means a high level, and it does not necessarily mean that it's lethal. In other words, an individual can have a toxic level of methamphetamine without having a cardiac arrest and death. So they're not synonymous.
Is that different than some other substances where toxic might actually mean toxic?
Yes, so there's certain things like cyanide. If you have a toxic level of cyanide, you will die. Methamphetamine is not like cyanide. So there are distinctions based on what drug or chemical we're discussing.
Yesterday, you were also asked questions by Defendant Collins' counsel about the sequence of events. Do you recall those questions?
Yes.
Is it your opinion that the restrictions on Mr. Ellis's breathing that occurred were after Mr. Ellis was restrained?
I'm sorry, could you repeat the question?
Sure. Is it your opinion that the only restrictions on Mr. Ellis's breathing that are relevant are the ones that occurred after Mr. Ellis was restrained?
Objective leading point.
I'm sorry, can you repeat?
Yes, objective leading point of the question.
The only
I'm sorry.
ones that were relevant? Is that what the
The only
question is?
restrictions, in terms of the sequence, you were asked about the sequence of events. Let me go back and ask you a better question about that. You recall being asked yesterday by defense counsel about there being a restraint and then there being pressure on Mr. Ellis, and then Mr. Ellis's decline. Do you recall
Correct.
And I'm just trying to clarify, was your opinion that the only restraint that mattered in terms of your opinion as to his cause of death occurred after he was restrained?
No.
And explain to us what your opinion is on that.
So the testimony I saw from the officers, most specifically Officer Rankin, indicated that Officers Burbank and Collins had Mr. Ellis in a prone restraint position prior to securing his legs with hobbles. So all of the time that he's in a prone position with officers on top of him, all of that is relevant in terms of creating a situation that can create hypoxia and that can lead to cardiac arrest.
I want to have you take a look at that. Do you recall being asked yesterday questions about an email from a woman named Julia Sherwin to me?
Yes.
You can take a look at Exhibit 2740. I just want to ask her some questions about the email. First of all, did you author that email?
Well, there is which section? Okay. No, the very first email is addressed to you, and I'm one of the people who are copied on that email.
All right. And just looking at the first paragraph of that email, can you just explain to us what this email says in terms of what Ms. Sherwin was attempting to do?
Yes.
Your Honor, I believe that this is following up on the way that was questioned about it yesterday with respect to the impression that was left with respect to what the email actually said.
Judges, here's
The difference is we were not introducing it for the truth of the matter asserted. Is that that this email was stated. Now the state's trying to offer evidence for the truth of the matter asserted. There's a difference there.
We're not offering for the truth of the matter asserted.
Well, I'll tell you about this. Restate the question, because now I've sort of lost track of what it was.
Sure, no problem. If you can take a look at the first paragraph, and can you just indicate what Ms. Sherwin was saying with respect to the email that she was writing to you, or to me, and copying you?
It's same objection, hearsay, being offered for the truth of the matter asserted.
Your Honor, it's offered to
And under 403.
explain the context of the contact,
Your Honor, it's
as
hearsay
well as
upon,
the last paragraph.
it is hearsay upon hearsay where Ms. Sherwin is trying to explain what it is that she's learned from Ms. East. It's hearsay upon hearsay. It in essence allows Ms. East to testify.
Your Honor, I didn't write the email. Counsel went into it yesterday and gave a misleading impression with respect to what the
That's not
email
true.
said.
That's not
Ms.
true at
Sherwin
all.
did not contact Ms. East. It's the other way around.
You want to know you want to ask him what was the point of the first paragraph? Is that really what you're asking?
What she said with respect to, because it goes to the issue of why she provided information about the topics that Dr. Dan could potentially provide information about. So that is, the first one explains why she would say that, which is the only paragraph that was focused on by defense counsel, why she's providing his name and explaining the context of why she's having contact with me.
Judge, I'd like to be heard outside the rest of the jury.
Sure. Ladies and gentlemen, please excuse us. Please do not discuss the case. Doctor, please excuse us for a few minutes while we have this conversation. Thank you very much for your patience.
Judge, can the court have the copy of the exhibit?
Well, I had a picture of a part of it. I don't have it anymore. And at one point in time, I was flummoxed here because I kept wanting to scroll it, and I can't. I just my capability. Well, it took me a moment or two to realize I can't scroll this document, so I can't see what else is on here. But how far is this? Is like a several-page document.
It's right there, it's fine, Judge.
Okay.
Judge, this is.
Wait, but hold on a second. Where is this going?
Well, Your Honor, yesterday they asked questions about this, suggesting that somehow that Ms. Sherwin was writing to me to say, hey, Dr. Dan will always say this stuff in the case. This is what he will say.
Yeah.
And this is, and if you look at the next paragraph, that's what counsel quoted out. Dan Wohlgelernter, cardiologist, can testify, blah, 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 blah. That's what they focused on.
Right.
They claimed that they suggested that she had said, hey, this guy will go ahead and say that. The first paragraph is clear that I had a conversation with her, that she knows I gave her facts about the case. I was seeking her input about potential experts. And she says, Patty, these are the experts I recommend who worked on this case with us before. Worked on these cases with us before. And prior to that, she talks about what the actual underlying facts were. So this isn't that Dr. Dan is some, dial him up and he's going to say these things. It's in the context of what I told her about the case and her having a similar case. Also, if you scroll further, you will see in the last paragraph that, and again, this is where I'm also going, because this is the prior report that they made such a show about yesterday about how it was somehow being copied.
Yeah.
She's saying that she's sending me another case that's just like or very similar to what Mr. Ellis's case is about. And that's why she's making the connection and saying that Dr. Dan is somebody that we should talk to. So I think it's important for the jury to understand the context of this email that was raised by defense counsel. And it's misleading to provide, this second paragraph or the third paragraph. And they also read about Dr. Freeman as if, hey, these are the experts that you always get in this case. That wasn't the context of it. I gave her specific information about my case, told her the type of experts that we needed, and she provided me, because she had some experience in this area, with the names of people that she's familiar with. That's the whole purpose of it.
Wasn't that clear from the questioning?
No, it was not clear from the questioning. The questioning was, in fact, very, I don't think, fair in terms of suggesting that she is saying, that she's just saying, hey, these are the guys I always use, and you should talk to this individual, this doctor. In fact, Dr. Dan it's a very similar case to the Martinez case, which they spent a lot of time on the report yesterday. And you will see it's very factually similar, raising similar issues, which is why they say copied from it. He's making general statements about PEA, about the medical literature, about meth and what kind of rhythm it produces, because it's a similar case. Also, right above this, you will see that defense counsel said, well, I thought you didn't solicit people. And in fact, you'll see that the email right above that is me responding and saying thank you, and I want to try to get in touch with you. And then Dr. Dan says, thanks, I look forward to speaking with you. Again, that email was left out, and instead just suggested that he then jumped on the bandwagon of soliciting, trying to get involved in this case.
Well, that last point, I agree with you. As to the earlier point, he made the point that these were things people were saying about him. This is what he was saying.
Right, I understand that, but you can't just read one paragraph out of context and suggest that somehow this was without any facts, without any knowledge. Here you go, why don't you go ahead and call this doctor, he'll say what you need to say. It's because she had facts about my case, and she had an understanding of her case, which is why she made that statement. So, that's why it's important for the jury to be able to hear it. It's not particularly prejudicial to the defense. It doesn't say anything different than what the jury already knows.
Which was what my point is. Didn't we have this already?
Well, we don't have it already because of the way that it was done. It was not, they were not, to take an email and only take a portion of it, and to take it out of context and not acknowledge why this is occurring is just really, I to, I'm gonna cover it briefly, but he should be entitled to say what this was, so that they understand that. Unless the court wants to instruct them that anything that Julia Sherwin said, they should just disregard. I don't think that it was relevant.
It's cross-examination. One of the things they were trying to point out, I believe, was you had a lawyer who wasn't involved with this case, who was involved in this Umberto case, evidently, which had different facts, obviously, some similarities, clearly, but some differences, too. It appears that Mr. Umberto was more physically injured, 16 broken ribs, petechial hemorrhaging,
Fractured thyroid, held in a carotid choke for 2 minutes until they turned purple.
right.
Yeah, and who had PEA, and who the defense claimed he died of an overdose. So, Your Honor, I mean, look, they're opening the door to it. We're entitled to put the full facts in front of the jury.
Well, before I finish, before you guys interrupt me any further, let me finish what I was saying, which was to say, isn't it unusual that this lawyer is able to predict what you're going to say in the case that you haven't received any information on yet, and then it turns out it's all exactly right? I think he explained that there were similarities, and this was their opinion, not mine, and my opinion was independent of this. I don't want to get into this whole business about what the lawyers say to each other. I think it's appropriate to point out the issue that once Ms. Sherwin evidently had made the introduction of everybody to each other, which is really what the point of the first email is, but also outlines the issues that might be of interest.
Can I ask whether or not
That you then asked him to get a hold of you, and then he did. He didn't respond to this directly. Only when you followed it up. I think that's fine.
That's fine, but can I at least ask him whether or not in this email it includes facts about the Ellis case as well as facts about the Martinez case?
Why? Because that's Ms. Sherwin's opinions,
I understand that.
not his opinions.
But I don't want the jury to be left with the impression that out of nowhere, with no facts about anything, she's saying, call Dr. Dan because he will say these things that you want out of the context of any of the case. That's just not accurate. It was in the context of her having knowledge about my case and giving me information about her case that she said, he's testified on these topics. He has expertise on this topic.
It seems to me you can get to this in a different sort of way. You can ask him whether or not Ms. Sherwin was the attorney in the Umberto case. And you can ask him to what extent there were similarities between the Umberto case and this one, without quoting Ms. Sherwin about all those things. The doctor can say that from his own knowledge. And, can ask him whether his opinion is independent of all that, and it just happens that they coincide in certain points, and maybe not in others.
I can ask him those questions. I do want to raise the issue of I am going to ask him about the report in Martinez to follow up on the allegations that this is just a cut and paste from that case, including the underlying facts on that case. And I have an exhibit 563, which is a compare and contrast to the reports that I offer for illustrative purposes. It shows how very little overlap there actually is between these two reports. But I think, again, it's fair cross-examination given what counsel did yesterday.
You're not cross-examining, you're directing.
Redirect in response to your.
I've never seen 563. This is the first time I've heard of it.
Excuse me, counsel, I don't have it on my, apologies.
I thought that it had been one of them. Here you go.
So we're going to need time to review that.
That's fine. It's a compare and contrast, as I said.
Was it
Simply
email?
a Word document.
Wait, so
Oh, I'm sorry. Here's your, I handed off all the copies. My apologies.
this looks like red line.
It is. It's a compare and contrast. It took the two reports, and it shows what portions are actually overlapping,
Oh,
which is
so-
only the black portion. You can see.
Okay, so if you took the
Humberto report and then edit it to fit in this report?
No, it takes the two, it's something you can do in Word. You can take two Word documents, and you can merge them, compare and contrast.
Hey, Judge, I'm going to need time to look at this. I don't have any issue with
The doctor going into the similarities or differences of the Humberto case, and that's why he included similar phrases. But I mean, how far we want to get into that is, I guess, up to the court.
Well, how much time do you need?
15 minutes? I gotta look at what all the changes are.
the other issue I want to take up with the court.
Is these speaking objections that are disparaging defense counsel in front of the jury, saying in front of the jury that we are misleading the jury, is completely improper. That shouldn't happen. Why are those comments being made in front of the jury that we are misleading? I mean, that's Ms. Eek's opinion.
Zeke's?
Your Honor, I was simply trying to explain to the court why I thought it was relevant, given the impression that had been left. And that's essentially what I said, is that the impression that was left by excerpting portions of that email, and not all of that email, was misleading. And that's what I was seeking to establish by just showing all of the email.
Actually, Judge, I think her statement was defense counsel was misleading, referring to me.
Well, that's not appropriate. If you think it's, if you think that there's more to be said about it, I mean, there's always the doctrine of completeness, and you can always raise that as an issue without characterizing the defense counsel. And of course, most of the time, that's something to be taken up on redirect. To say, well, what they said was so far so good, unless it is a misquote. But then here's the rest of the story that they didn't talk about, right?
Judge, I'm already seeing, just by looking at this, I'm already seeing issues with how they've done this, right? Because they make it look like he's crossing out certain things. It's just like reverse order, like the reviewed materials, that they've crossed out all the materials from our case and included the materials from the Humberto case. And then,
The program does it automatically, if I may just explain it a little bit. Counsel's not familiar with it. So if you take two documents that have been changed, or that are said to be the same, and you want to see what the changes are, just like when we file things and someone files a revised one, the program automatically shows what the differences are. All it's showing is that is the differences between the two reports. So, for example, on the first page, if you look at where it says I've reviewed the following materials, that's everything that's X'd out is the stuff that was in the Ellis report.
But then it's including the materials from the Humberto report, but then if you go to pertinent medical history, what's not X'd out is all the Humberto materials, right? And then X'd out is Mr. Ellis's materials. So it reverses order when it's convenient.
I believe it's the same, what it's always Xing out is the Ellis materials and not the Humberto materials.
Why not just go through the differing reports and point out the differences? I think that this is, I mean, we wouldn't publish the reports. I don't think that's appropriate.
showing, Your Honor, is that the black is the only portion that is the same between the two reports. That's what it's showing. And as you can see, the rest of it is not the same, which is not the impression that was given to the jury yesterday in cross-examination. Instead, the impression was given that it was a cut and paste, is I think the language was used, of these two reports.
Well,
There was opinions. His opinions are the exact same cut and paste. That's what it was. And he said, yes, there's many other. He testified, you're not that those are not all the sections of the report. And I acknowledged that. I said, yes, of course, but this is the opinion section, right? And that if you read his opinion section, that that it was word for word the same, except for Mr. Ellis is supplanted in there in reviewing the literature and as confirmed in my extensive experience as a cardiologist. The only plausible and possible cause of PA arrest and then he switches out Martinez for Ellis.
But that's not accurate. That's exactly my point. If you look at the opinion section, you've got a little bit of black starting at like page 5, and then you see all that's different is from the Martinez case. Then you see what is in the Ellis case is not in the Martinez opinion. The only overlap is this generic statement about pulseless electrical activity.
do you plan to show this to the jury?
This is an illustrative, yes.
The problem with that, it seems to me, is then you're essentially showing the jury the report of the doctor, whether it's lying down or not. Never mind the Umberto report. You're showing the entire Ellis report, right?
Well, it's lined out.
Yeah, but they can still read it.
Yeah, I mean, if you prefer me to go through line by line and read it, then we'll do it that way. That's fine. I think that this illustrative shows and can more quickly go through the fact that they are not cut and paste from each other.
Well,
I mean, even in the section that says I totally reject the contention, which again, counsel read from, just portions of it, you can see on that page, on the last page, before it says sincerely yours, second to the last page, that it's different. So again, the statements being made that this is some cut and paste is just not accurate.
I have no opinion about all that, but I don't think this document is appropriate to show the jury. Also, to the extent it shows, in a sense, both documents simultaneously, it tends to make the differences appear greater than they are, too. Because it shows all the Gonzalez material, all the, if you will, history of that. It shows that's there, and then it shows all the Ellis history. That's all gone out. Where that's just, which sort of doubles the size of the difference in a way.
We can just go through it by paragraph if that's
But as I say, it also shows them the report of on the Ellis matter. Never mind that the Gonzalez matter is, of course, basically irrelevant to this, but. Well, it's not completely irrelevant. I mean, all the details of it are irrelevant, I suppose, but to the extent the doctor needs to explain that, to the extent that the conclusions are similar, it's because it's, in his view, is similar in terms of its factual support, so, and presumably medical support. And he's certainly entitled to offer that as an opinion. And I think he's done that already in his responses. But that doesn't mean you can't go there. But this exhibit is problematic. 563. Anyway, so are we straight about the email?
yes, I understand.
And we're straight about 563?
Well, Judge, I'm not sure we're clear on the email. I'd just like to know specifically what counsel
Well, she's not going to refer to the email quite so much, but she is going to talk about the email where once there was this email provided an introduction, that she contacted him and then he responded. It wasn't that he solicited her.
Not a problem.
What? Okay, that's one part. And the other part is that, you know, to establish the factual basis that this lawyer was involved in the Rodriguez case, that Gonzalez case, Martinez case, I'm sorry, and thought that some issues were the same, and provided an introduction with all this.
That's fine, it's generic like that, and it's not a
And then the doctor can answer various questions about all that. And he can talk about the intersection of facts or medicine between the two cases, I suppose, to explain why some opinions would be the same in each. She's entitled to do that. I don't see any problem with that. I don't like the reference back to the lawyer's opinions as such, but she merely provided an introduction. And then things went from there. Okay. Are we ready for the jury?
I'm just gonna go speak to Dr. Dan so I understand the limitations of the email that I'm asking.
Well, if you ask him the right questions, I'm thinking it should be fine.
Well, I don't want it to go into the wrong thing.
Okay, that's fine. It's going to take a moment or two to get him back here. Although I'm thinking Mr. Conrad has something else to say.
Yeah, I'm wondering if there's some cure to the comment that we were misleading by Ms. Eakes, because I don't want the jury to have that impression. So I'd like some correction on that because I don't think that's accurate.
You have a proposed instruction?
Disregard the comment by Ms.
Disregard
Eakes
the
that
comment by
counsel
Ms.
was
Eakes that we were.
Ignore Ms. Eakes?
No, not ignore Ms. Eakes, but disregard the comment by Ms. Eakes that we were misleading.
All the defense lawyers want that. Some may prefer not to have it emphasized.
I actually don't care, Judge.
I think we just leave it alone.
All right,
I think her
that's
opinion
fine.
means nothing. So
Well,
So you want me to do nothing?
Yes.
Oh, I've mentioned before, I'm good at that. Let's have the jury back. And you can talk to your doctor.
They're making you work hard, Your Honor.
They are. You too, doctor.
You too.
I hope my heart can take it.
I was going to say, I was driving down the freeway yesterday and I was thinking, all these people in these cars.
We'll at least get you done today and have a safe trip back.
Thank you, Your Honor.
to your 80-degree weather down there. Welcome back, everyone. Please be seated. Okay, let's start again, Ms. Inks.
Thank you. Doctor, we were looking at 2740, back up on your screen there. And this is an email you were asked about on cross-examination from Julia Sherwood.
Yes.
And can you tell us, and you were also asked questions, by the way, about a report involving Mr. Martinez. Do you recall that yesterday?
Yes.
What was Ms. Sherwood's role with respect to the Martinez case?
She was the attorney representing the Martinez family.
And she's the person who made the introduction of me to you, is that right?
Correct.
All right. And were there any similarities between the Martinez case and the Ellis case?
Many.
And what similarities are there?
Mr. Martinez was 32 years old. Mr. Ellis was 33 years old. Mr. Martinez was involved in an encounter with law enforcement, and he was very active before he was placed in prone restraint, running into a garage and into the house. Officers had to pursue him, and just as Mr. Ellis was very active before he was put in restraint. Both cases involve taser application, and both cases, Ellis and Martinez, involve officers placing the individual in prone restraint, with two officers in the Martinez case applying pressure to Mr. Martinez's upper back. We've talked about the circumstances with Mr. Ellis. And in both cases, there was cardiac arrest. And in both cases, there was PEA. PEA not that I established, but PEA that was established by the paramedics in their report, and also by a cardiologist who saw Mr. Martinez when he was taken to the hospital, where resuscitation was applied and was unsuccessful. So in both cases, there was death after prone restraint. Autopsy in Mr. Martinez, similarities to the autopsy in Mr. Ellis. Cardiomegaly, Mr. Ellis was 480 grams. Mr. Martinez was 540 grams. Hypertrophy seen in both cases. And there was methamphetamine in both cases, both in our case, Mr. Ellis, and also in the Martinez case as well.
So going back to the email of 2740, after Ms. Sherwin made the introduction, introduced you to me via this email, can you look at the second page of the email, and who responded then?
So you, Patty Eakes, responded to Julia Sherwin and copied me as well as other doctors or experts that would potentially be involved.
Okay. And is that when you then responded to me when I reached out to you? Is that correct?
That's correct.
All right. We can take a look at 2743. And do you recognize this as the report in the Martinez case that you were asked questions about yesterday?
Yes.
All right. And you were asked a series of questions about overlap or statements that were made in the Martinez case as well as statements that were made in the Ellis case. Do you
Yes.
recall those questions?
Yes.
All right. And can you just kind of walk us through, or walk the jury through that report in terms of did you, in that report, in the Martinez report, did you talk about the underlying facts in the Martinez case?
Yes, I did.
All right. And I think you mentioned a few minutes ago that there was some restraint and weight on Mr. Ellis, or excuse me, on Mr. Martinez.
Yes.
All right. And was there indications from the paramedics in that case as to PEA in the cardiac monitoring of Mr. Martinez?
Yes.
And I think you also mentioned that there was underlying heart issues as well,
Yes.
and issues related to methamphetamine, is that correct?
Yes.
All right, so let's talk about the portions that defense says that you have copied from the Martinez case. First of all, looking at that, looking at the report at page 4, can you tell the jury what did you write was your opinion with respect to Mr. Martinez, paragraph 1?
Okay. So I'm just reading from this report.
It's not too fast for the court.
I would never do that. Okay, this report was authored in December of 2018. So paragraph 1 of my opinions in that report, Martinez. It is my opinion, with a reasonable degree of medical certainty, that Mr. Martinez's death was due to restraint/compressive asphyxia with mechanical obstruction of respiration, with bilateral anterior rib fractures, parentheses, clinical flail chest, close parentheses, soft tissue injuries on exterior of neck and of strap muscles, contusions and hemorrhages into neck soft tissues with fractured thyroid cartilage. These injuries were caused by the chokehold and trauma to Mr. Martinez's chest and neck from multiple punches and compressive force applied to his torso by the police officers, with resultant respiratory compromise and subsequent development of hypoxia/hypoxemia causing PEA cardiac arrest.
Okay, let me stop you there. Then the next paragraph talks about PEA, is that right?
Yes.
All right, and is the first sentence essentially the same as what you had in Mr. Ellis's case in terms of describing PEA?
Yes.
And why is it the same, doctor?
Well, it's the same finding. I mean, PEA, Mr. Martinez had PEA, as noted by the paramedics and the cardiologist involved in that case. Mr. Martinez had PEA and Mr. Ellis had PEA. PEA is a phenomenon that's not unique to an individual. So if you have PEA, whether your name is Ellis or Martinez or anything else, it's the same description. It's the same process. So I would use the same words describing it, regardless of the case.
And you were also asked questions about, in the Martinez case, statements that you made with respect to the rhythm associated with methamphetamine and whether or not methamphetamine was the cause of Mr. Martinez's death.
Yes.
All that?
Yes.
Okay. And was that a defense that was being raised in that case?
Yes.
And can you tell us, does it matter, the statements that you made about methamphetamine and the rhythm that you would expect on a EKG as a result of that, does that change from a meth overdose, whether it's Mr. Ellis or Mr. Martinez?
No. The analysis about how methamphetamine...
Well, he's explaining it. It was a yes or no kind of question, but I'll allow him to explain it. You may continue, doctor.
So the discussion about methamphetamine and how it would theoretically cause a cardiac arrest, that's the same regardless of the situation. We're talking about what methamphetamine can do and what it cannot do. That's not unique to an individual. That applies in any case where methamphetamine is suspected as being the culprit causing a cardiac arrest.
If I could have just a moment. I don't have any further questions. Thank you.
Recross.
Doctor, good morning.
Good morning.
I want to go back to the Mr. Martinez case and comparing it with the situation. As I believe I understand your testimony, they're comparable. Is that correct?
There are similar facts and similar outcomes. So I'm not sure what the word comparable would mean to you, but there are certainly similarities.
Well, you just reported to Ms. East that they're comparable cases. I just want to make sure I'm correct in my terminology.
Yes, I'll live with the word comparable, yes.
And so you stated that, or the information regarding Mr. Martinez is that he was tased, correct?
Yes,
And in this case, Mr. Ellis also was tased.
yes,
It states that Mr. Martinez was stumped, correct?
hearing your word. I don't specifically recall the word stomped, but if it's there,
Well, I'm referring to the email 2740, exhibit 2740.
okay, I'm relying on my report. So do you want me to, you're asking about someone else's
Well, I wanna
comments?
make sure that we're all talking apples to apples here. You sound like we've got different information coming from a variety of sources. So I'm just trying to figure out what's accurate.
I have an objection with respect to the reading of the email from Ms. Sherwood, based on the discussion we just had.
Judge, I'm just asking questions related to what is in the email, with the specific report.
Sure, but he wasn't the author of that email. So to the extent they're different, I don't know how this witness can be expected to respond to it. Now, if you're reading from his report in the Martinez matter, well, then that's obviously, he's the author of it, and we got something different.
Do you recall if Mr. Martinez was stumped?
I have no recollection of that.
Okay. Do you recall if he was kicked?
I have no recollection of that.
Do you recall if he had 16 broken ribs?
I don't remember the number of broken ribs. I know that he did have broken ribs, and I referred to that in my opinion paragraph.
How many ribs does a person have?
12.
Okay, and so
Yeah.
there's a reference that he had 16. Is that correct or incorrect?
Well, there are 12 ribs on each side, so it could be 24 ribs fractured theoretically. Yeah.
3/4 of his ribs were broken,
I don't have a recollection specifically of how many ribs were broken.
but multiple ribs were broken.
Yes.
All right. That he had a flailed chest.
Yes.
What is flailed chest?
Flail chest means where the expansion of the lungs moves in paradoxical directions. So the chest moves out, and the lungs don't move with the chest.
Is that a congenital issue, or is that something caused by the behavior that the officers in this particular case were working?
It would be due to the rib fractures.
Rib fractures.
Yes.
How many rib fractures did Mr. Ellis have?
None that I'm aware of.
None. Okay, and did he suffer from a flailed chest?
No.
That flailed chest would be a reason why he couldn't breathe, correct, Mr. Martinez?
Yes, and I acknowledge that in my opinions.
Okay, you acknowledge it, but Mr. Ellis didn't have any broken ribs,
Correct.
did have a flailed chest,
Correct.
and he could breathe throughout the event, correct?
Well, depends what you mean he could breathe. He kept on saying, I can't breathe.
Well,
And
he
he,
said that, but he was breathing up until the point in time, 10 minutes after paramedics arrived, that apparently he needed assistance to breathe.
so he had stopped breathing at that point, but he was described as having agonal breathing
Well,
by
he was
by
who?
police officers.
By police officers. How
Right.
much training are you aware the police officers have with respect to the type of breathing that a person might encounter?
I'm not familiar with the extent of training. I know that that was a term that was used, so obviously the officer felt comfortable enough to use that term.
Do you know if the officers knew what agonal breathing meant?
I don't recall whether that was specifically asked in the interview.
With respect to the Martinez case, he suffered from petechial hemorrhages in both eyes.
Yes.
Correct? And that is a sign of restraint around the neck, correct?
Yes.
And he had petechial hemorrhages in both eyes, right?
Yes.
How much did Mr. Ellis suffer from any petechial hemorrhages?
No.
And also, Mr. Martinez had a fractured thyroid cartilage, correct?
Yes.
Where is the thyroid cartilage?
In the neck.
In the neck. And
Yes.
that would also be from strangulation, correct?
Yes.
All right. And so there is a lot of dissimilarities between Mr. Martinez and Mr. Ellis, correct?
In that sense, yes.
But you returned the same opinion regarding both cases.
Well, I commented about the injuries. I didn't say the same things about each case. So,
Your opinion was the same in both cases regarding
no,
these.
no, my opinion regarding the injuries was not the same.
I'm not talking
I,
about the injuries, I'm talking about your opinion.
okay, I have an opinion about the injuries that was stated in my opinion section. So that's opinion. Look at cardiology opinions, page 4, and I talk about the rib fractures, and I talk about the thyroid cartilage.
Is that
So,
an opinion or is that a fact?
it's in my opinion section.
I understand that. My question is that an opinion or is that a fact?
Well, that sentence says an opinion.
The question is that an opinion or a fact that Mr. Martinez suffered from rib fractures?
Do you want to let me answer the question?
I want you to answer my question.
It's an opinion, because I talk about the mechanism of his asphyxia.
So your opinion is that he suffered rib fractures.
My opinion is that he had mechanical obstruction of respiration related to the rib fractures.
Did Mr. Ellis have that same situation?
I've already acknowledged that Mr. Ellis did not have rib fractures.
So with respect to the situation where Mr. Martinez was beat up by the police officers, that occurred, correct?
I didn't use the term beat up.
I used the term. He was beat up by the police officers, correct?
So you're offering opinions to me?
I'm asking you a question, doctor.
I'm not acknowledging any statement about
So
beat up.
did he fall off a ladder?
The question is, in the Martinez case, how were the fractured ribs sustained?
How were the fractured ribs sustained in the Martinez case?
As a result of the encounter with the law enforcement officers.
And are you aware of what the encounter with the law enforcement officers was?
I was aware to the extent that I have that included in my report. I don't have any additional recollection beyond that.
Well, you referenced that one of the officers applied a chokehold to Mr. Martinez's neck, correct?
Yes.
That another officer punched Mr. Martinez in the abdomen and the ribs, correct?
Yes.
And apparently the strikes to the ribs was sufficient to break multiple ribs, correct?
I'm not assessing the mechanism of how the ribs were fractured, whether it was due to the punch, whether it was due to being placed in prone restraint. That was not my role in the case.
Just that he had broken ribs.
Correct.
Okay. What was Mr. Martinez's methamphetamine concentration?
I don't recall.
Was it 2,400 nanograms per milliliter?
I don't recall.
Do you recall it was less?
I don't recall.
Just that he had meth in his system.
Yes.
But you don't reference that in your report.
I do refer to the fact that he had methamphetamine.
But not the quantity.
Correct.
Not a toxic level.
I don't recall what the level was.
If it was a toxic level, would you include that in your report?
This was 5 years ago. I don't know what my practice pattern then was.
Doctor, with respect to, if we could go put on the exhibit 2739 back in front of the doctor. Doctor, this is the med pack for the medical device showing the EKGs of Mr. Ellis and seeing.
Yes.
Can you show us where on this particular chart that he experienced the tachycardia, the ventricular tachycardia?
So we'd have to scroll
If you could
later.
just scroll.
Here we go.
So where does it start, just so we understand?
Maybe go back earlier.
Okay.
So 11:42, 45.
Okay. And you indicated yesterday, I think you said that was as a result of the epinephrine.
Yes.
Whenever a patient receives epinephrine, do they experience tachycardia?
No.
Do you have an opinion to why Mr. Ellis experienced tachycardia in this particular case?
Speculative. I mean, he got 7 doses of it. That's an enormous amount.
This after the first dose.
Okay. As far as that issue, even 1 dose can do it. He has underlying cardiomyopathy, which makes him more sensitive. And he has methamphetamine on board, which would make him more sensitive as well.
Okay. So we can't ignore the methamphetamine toxicity.
I've never said that I'm ignoring it.
I understand. And the dilated
I've never said that I'm ignoring it. I've always acknowledged it.
And the treatment, as going through this course, or the course of treatment, the doctors or the paramedic were not aware of either of those issues, is that correct?
Correct.
With respect to, you indicated, I think yesterday, that Lieutenant Wilson, he had Mr. Ellis hooked up to the EKG at the time that he arrived, correct?
Yes.
And I believe you also testified that Mr. Wilson said that he didn't have a pulse in the prior interview with the Attorney General, correct?
Correct.
If you could take a look at Exhibit 805, or excuse me, 802. We can put that up and take down, just give a doctor Exhibit 802. Let us know, doctor, when you have it.
Not yet.
It's coming.
Okay, it's up there.
Okay, and doctor, you could turn to page, well, strike, if you recall where in Lieutenant Wilson's interview that you saw this?
No, I'd have to scroll through the
Let me see if I can
transcript.
copy there. You could turn to page 40. Are you at page 40, doctor?
Yes.
Okay.
Is there a question?
Actually, turn to page 42, line 15. But we'll turn to that for you. You see that?
Yes.
And if you could read from page 42, line 15, to the line 2 of, on page 43.
So beginning with line,
Line 15 on
okay.
page 42 to line 2 of page 43.
You want me to read it out loud or?
Read it to yourself.
Okay.
Let me know when you're done.
Okay, so we'll need to go to the next page. Yeah. Yes.
All right. Lieutenant Wilson's talking about having a pulse during his initial encounter with Mr. Ellis, correct?
Yes.
Now, you had testified, actually in your report, you indicated that in your report, doctor, you indicate I guess, that when the life pack was shown, that when the initial rhythm was established, that he was in PEA. But
Yeah.
then after lunch, he came back and said, well, no, he actually had a pulse. Just want to know what exactly your position is today.
If we can go back to page 42 of this
Well, it's not
interview.
on the 42. It's what you testified to yesterday.
So what, okay, are you talking about today's testimony or yesterday's
I'm talking about
testimony?
yesterday's testimony. Yesterday
Okay.
in the morning, you were asked when did the PEA start?
Yes.
And the exact time was 23:37:32. After lunch yesterday, you came back and said he actually had a pulse when the life pack was started.
So I'm relying on, I wasn't there to examine Mr. Ellis, so I'm relying on testimony. Yesterday we were talking about Lieutenant Wilson's trial testimony, in which he said that Mr. Ellis had a pulse up until a later point. And reading Lieutenant Wilson's interview testimony from March of 2021, a year after the incident, the timeline is less secure, and he also acknowledges and uses the term PEA.
If you could take a look back at the exhibit you got, you need page 41, line 23. You see that, Doctor?
Not yet.
Okay. Let me know when you got it.
I have it, yes.
Okay. And if you would please read to yourself on page 41, lines 19 through 23. Actually, 19 through 25.
Yes.
And then actually, that's one, yes, next to page 42 as well. Down the line there.
Yes.
So, Lieutenant Wilson stated back in March 25th of 2021 that he had a pulse before initiating CPR, correct?
Yes.
And he said that his level of suspicion was heightened not only by the fact that he's not breathing on his own because he's a bag valve mask on it, right?
Yes.
But now we have an EKG that's slowing,
Yes.
correct? So there was a pulse immediately upon the life pack being placed upon Mr. Ellis, correct?
Yes.
And that's why they didn't start CPR at that point, correct?
Correct.
And then 4 minutes later, they started CPR.
That's what it seems to be. Yes.
It doesn't seem to be back in 2021, but that's exactly what Lieutenant Wilson testified to previously here, correct?
So I recall from this interview that Lieutenant Wilson admitted that he's a bit vague about exactly what the timing is.
He had his Exhibit 24 at the time of his interview, correct?
Yes.
The Exhibit 24 has the specific times in which there was a pulse and the specific time in which he started CPR, correct?
Yes.
All right. So your testimony yesterday was not accurate regarding what it was showing on these particular records, correct?
Argumentative.
Well, he didn't say anything indifferent. I don't think he said anything different about the records. What he said was is that Lieutenant Wilson said something different in this interview than what he testified to.
Let me ask you a different
So
question.
I think that's what you're trying to straight out.
Well, Doctor, Lieutenant Wilson documented in his pre-hospital care report the time frame for the specific time when the EKG was started and then when CPR was started, correct?
Yes.
All right, and that was a 4-minute difference, correct?
I have your question in mind. Yeah.
Page 2. Exhibit 24.
Yes.
So, Mr. Ellis had a heartbeat when they first arose.
Yes.
He was having difficulty breathing, correct?
And then ultimately stop breathing.
Well, my question, he had difficulty breathing.
Yes.
He was bagged for 4 minutes,
Yes.
and then an endotracheal tube was placed in.
He had stopped breathing when they put the bag valve mask on it.
Yeah, but
He had actually stopped breathing,
he stopped breathing.
but still had a pulse.
CPR
Yeah.
started,
Right. Yeah.
correct? And an endotracheal tube was placed in as well.
Yes.
And actually, going back, Doctor, to your report in Mr. Martinez,
Well, maybe this is the time to break. It sounds like you're going to a slightly different topic, because we didn't take the morning recess. So we'll take our recess now for 15 minutes. Ladies and gentlemen, please do not discuss the case among yourselves or with anyone else. Thank you. Sir, you may resume when you're ready.
Doctor, I'm just curious, this morning on redirect, you said that Lieutenant Wilson didn't say that he felt a pulse. Do you recall that testimony?
I don't specifically recall that statement. What I said was that Lieutenant Wilson said that when he saw or felt an absence of pulse, there still was an electrical rhythm, which he then called PEA.
Right, yeah, but who told you that in his prior statement to the Attorney General that he said that there was no pulse when he first arrived?
Who told me? I'm not sure. I read his transcript. Yeah, yeah, right.
But his transcript clearly stated that he felt a pulse when he first arrived, correct?
Yes, but that's the point that I made, was that at a point when there was no pulse, there was electrical rhythm, according to Lieutenant Wilson's testimony, and he characterized that as PEA.
And that was 4 minutes after he initially arrived, correct?
To the extent that that timeline is totally accurate, which I believe Lieutenant Wilson in his testimony said he couldn't vouch for the timeline being totally accurate. And my experience with cardiac arrest situations is that it's hard to have the exact timeline because the people involved are doing so many things.
Well, the timeline that he had in exhibit is pretty accurate, isn't it?
We have no independent way to know that it's totally accurate. I mean, there's...
He's been a paramedic for 20-some years.
Yes, I know, and I have participated in many cardiac arrests, and there's a lot that's going on. You're trying to resuscitate the patient, you're trying to measure the heart rate, you're trying to look at the EKG, you're giving oxygen. Recording the actual timeline and syncing that with the clock is often not accurate.
He's punching a button.
Yeah, but when you punch the button isn't necessarily exactly when that action happened, because you're doing so many things.
He's not a rookie.
I didn't say he was a rookie.
But you're saying he's not accurate with respect to what he's done?
No, I didn't say that he's not accurate. I just said that there are often inaccuracies built into the process. I'll tell you what's accurate here, and I think indisputed, is that he was not...
Question pending to you.
I thought there was.
No, there's not.
Okay.
There's a 4-minute difference between the time that he hooked up the EKG until the time he started CPR. Correct?
Correct. And so he was not breathing, but he did have a pulse. So, which is totally and absolutely consistent with it being primarily a lung problem. Because if it's a heart problem, you lose your pulse first, and then you stop breathing. The fact that he was not breathing and for as much as 4 minutes still had a pulse indicates that this was primarily a lung problem, restraint hypoxia, and not a cardiac event due to methamphetamine or due to his underlying heart disease.
What's that got to do with the inaccuracies of his time?
No, I'm talking about your stipulating to me and challenging me with the fact that he still had a pulse 4 minutes later.
There was 4 minutes between the time of hooking up the EKG till the time he started doing CPR.
Okay, and I'm telling you that that is significant.
Doctor, with respect to, in going back, and I apologize, I missed this, in Mr. Martinez's case, there was additional differences between Mr. Martinez's situation and Mr. Ellis's situation. He had soft tissue injuries on the exterior of his neck and on the strap muscles, correct?
Yes.
Did Mr. Ellis suffer from that type of malady?
No.
He had a horizontal fracture of the sternum, correct?
Yes.
And the sternum is like right here in the middle of the chest.
It's the breastbone, yes.
It was broken.
Yes.
Pretty painful, correct?
I've never had it, but I would imagine it would be, yes.
And you said you didn't recall the number of fractures that were broken, but in your report it indicated that the left ribs from rib 1 through 9 were broken, correct?
Yes.
And the right side, rib 1 through 7 were broken.
Yes.
And he also had liver contusion.
Yes.
Did Mr. Ellis suffer any of those types of injuries?
No.
I also asked you with respect to the methamphetamine level, you said you didn't recall, but do you recall recalled that the methamphetamine level was 0.62 milligrams per liter.
I didn't have a specific recollection, but if you've found that in the review of the report, then I'll acknowledge that being the case.
And so Mr. Ellis's methamphetamine level was 4 times that amount, correct?
Yes,
You indicated that the methamphetamine level, 2,400 nanograms per milliliter, was toxic but not necessarily fatal.
correct.
If you ingested 2,400 milligrams of methamphetamine right now, would you survive that?
I'll tell you what. I'll let you ingest it, and let's see what happens. Yeah,
Would you survive it?
I don't want to do that trial, but if you're up for it, go ahead.
Would that be a fatal dose, would it not?
So there's a big difference between.
My question is, would that be a fatal dose? Not answering the question.
Please listen closely to the question and answer the question.
Question answered yes or no. Would that be a fatal dose if you ingested 2,400 milligrams of methamphetamine?
I suspect it would be.
And doctor, lastly, you indicated that you don't ascribe to the idea of excited delirium being the cause of death, correct?
Yes,
And it's suggested as if that was the defense position in this case, it was excited delirium that caused Mr. Ellis' death, correct?
I didn't suggest that.
Well, the cause of death noted by the first individual, and understanding he's not a pathologist, but the first individual that saw Mr. Ellis was Lieutenant Nicholas Wilson, correct?
Yes,
And the cause of death that he indicated was cardiac arrest secondary to excited delirium.
yes,
There are doctors that still accept excited delirium as part of the death process, correct?
yes.
Doctor, thank you very much.
Thank you.
Mr. Esser.
Morning.
Ms. Peak started her redirect this morning, having you look at Exhibit 2742, which was the materials that said that you primarily relied upon in reaching your conclusion. Do you remember that?
Yes,
And if I understood correctly, that you indicated that you use the word primarily because some of those are significant in reaching your conclusion, and some may not have been included that wouldn't have been as significant. Is that fair?
yes,
All right. And if I understand, the most significant things for what you were asked to do would be any information relative to the restraint of Mr. Ellis and any pressure put on Mr. Ellis during either the restraint process or after restraint. Would you agree with that?
yes,
Okay. And I think you said when Ms. Eakes asked you that you relied on the testimony of Officer Rankin to kind of give you some facts to support your opinion.
yes.
Well,
But not exclusively on Officer Rankin, yes.
you understand that the initial officers that came into contact with Mr. Ellis were Officers Burbank and Collins,
Yes,
and that they were engaged with Mr. Ellis for upwards of 2 or 3 minutes before Officer Rankin arrives.
yes,
You understand that?
yes,
And Officers Burbank and Collins were the officers who initially got the handcuffs on Mr. Ellis prior to Officer Rankin arriving. Did you understand that?
yes,
All right. So they would have the most significant information relative to what you were asked to do in evaluating this case. Would you agree with that?
no,
Will they give you the time that they were interacting with Mr. Ellis prior to restraint?
yes,
They would give you how difficult it was to restrain Mr. Ellis, right?
that's not relevant to me.
Okay. They would give you information about weight applied from them to Mr. Ellis,
Yes,
how long it was applied,
yes,
any resistance from Mr. Ellis in the application.
again, that's not relevant to me.
Okay. Did you review either of their statements?
Yes, I did.
That wasn't included in the things that you said you primarily relied upon.
Yeah, that was an oversight.
Okay, so you did review their.
Yes,
Okay. So then you understand that the interaction started when Mr. Ellis began punching the patrol vehicle,
yes,
and that they tried to restrain Mr. Ellis and he resisted being restrained.
yes,
You understand that that struggle lasted for upwards of 2.5 to 3 minutes before other officers were able to respond, right?
yes,
you understand that they had to use a taser application to try to get Mr. Ellis' hands behind his back and cuffed. You understand that?
Yes.
And I think you testified both yesterday and today that the taser application creates a greater need for oxygenation, potentially because of the pain.
Correct.
Are you aware that after the first taser application, that Mr. Ellis told them to try it again?
I don't recall that. I'm not denying it, but I don't recall it.
Meaning after the application to tase him again. Were you aware of that?
I don't recall that, reading that.
Do you recall that he was tased in upwards of 3 separate times in order to get compliance to get into the
I don't recall the specific number.
More than once? Do you understand it's more than once?
Yes.
All right. We went through, I'm not going to do it again, but we went through it ad nauseam, all the different contributing factors that were present in Mr. Ellis that required additional oxygenation to survive.
Yes.
Okay, including the stuff we just talked about, right?
Yes.
And I think you said yesterday that those factors would create somebody that's restrained like Mr. Ellis to deteriorate far more quickly if those did not exist. Do you agree with that?
Yes.
Okay. Would you also agree that in order to seek the medical aid for Mr. Ellis, the officers have to make it safe for the paramedics to get there to administer the aid?
Yes.
Which means they had to restrain Mr. Ellis in the manner that they did in order for the paramedics to treat him.
Well, I'm not here to endorse or criticize any of the tactics used by the police. That's not my role.
Okay, but you would agree that in order to get him aid, they had to make it safe for the paramedic to come and treat him.
That makes sense to me. Yes.
That's all.
Thank you.
Mr. Conrad.
Clarify a couple things. Try to. So we went through one of the rhythm scripts from the life pack data
Yes.
during the cross-examination, and that was the time period of that we looked at was 11:37:40 to 11:37:50. Remember that?
Yes.
And I counted up the different pulses or the different beats that would have been present.
Yes.
And so and you agreed with me that that's not a Brady beat, right?
Correct.
It's not normal sinus rhythm, right?
Correct.
It was a tachycardia beat, a fast heart rate.
Right. Not ventricular tachycardia, but tachycardia in the simple sense. Yes.
Right. It was still an arrhythmia, though.
Yes.
Right. It was an irregular heart rate.
Correct.
Okay. And there was no epinephrine that had been administered at that point, right?
Correct.
So he has a fast heart rate at that point, right?
Yes.
No epinephrine.
Yes.
And he has an irregular heart rate as well.
Yes.
And you've acknowledged that you believe that it's atrial fibrillation, right?
Yes.
You've also said, atrial fibrillation, people walk around with that all the time, right?
Yes.
You have patients that walk around with that all the time.
Yes.
How many of those patients that are walking around with atrial fibrillation have lethal amounts of methamphetamine in their system?
Not the patients in my practice.
Okay.
Yes.
And how many of those patients with atrial fibrillation have cardiomyopathies as well?
Some of them do.
Okay.
Yes.
And how many of those patients also have hypertrophy as well?
Some of them do. Yes.
And how many of those patients have just attacked a police vehicle and got into a altercation with police?
None that I'm aware of.
Okay. And how many of those patients are on pretrial release and not supposed to be using
I
methamphetamine?
can object to that. It's outside it's argumentative and outside the scope of the doctor's knowledge.
Well, as I understand this, there's also an emotional component to all of this. It has not been touched on a lot, but it's been touched on. And I think even the doctor did too. And it may be an emotional thing to realize he may be going to jail for those reasons about his pretrial release conditions. And that may have contributed to his sense of fear or panic or distress, which, as I say, this has been touched on very slightly, but presumably could have increased his need for oxygen. So I don't think this is beyond the pale, so I'll overrule the objection. You may.
So how many of those patients that you said walk around with atrial fibrillation are on pretrial release and not supposed to be using methamphetamine, do you know?
None that I know of.
You'd agree with me that atrial fibrillation that's accompanied by low blood pressure will inhibit the heart to perfuse properly.
Can you repeat the question?
Yeah. Atrial fibrillation, right, an irregular heart rate,
Right.
atrial fibrillation with low blood pressure will inhibit the heart to perfuse properly.
No, not necessarily. It depends on how low the blood pressure is and how rapid the atrial fibrillation is. So, not necessarily. Yeah.
But given those nuances, those two things can cause perfusion problems within the heart, right?
Potentially, yes.
Okay. And when you have perfusion issues, you talked about in direct examination this orchestra, right?
Yes.
And you said it's got to be a symphony. We all have to be playing together at the same time.
Yes.
You can't have the trumpet going off and going when he's not supposed to be going, right?
Yes.
Okay. And with atrial fibrillation, the atrium, right,
Yes.
is going off and doing its own thing, right?
Yes.
Okay, so let's say the atrium is the trumpet. The trumpet's sounding out when it's not supposed to be, right?
Yes.
And I think you even used that there's some chaos there, right?
Yes.
Okay, so the heart is not in this symphony at that point, correct?
Yes.
Okay. The other thing I want to talk about is you talked about agonal breathing as well.
Yes.
Agonal breathing can have many different causes.
Yes.
Okay. Including cardiac issues, right?
Yes.
Okay. And you've talked about asystole as well. Asystole is kind of the last rhythm that you see many times, right?
Yes.
Okay. And asystole can also be caused by cardiac issues.
Yes.
Okay. And one of the things you said that if it's a heart problem, you lose a pulse. Is that what you said?
Yes.
Okay. But we've also talked about heart problems right now, given the symphony analogy, right?
Yes.
Okay. And if you have those problems, if you have perfusion problems and circulation problems, that can also lead to hypoxia as well, right?
No.
So you're not oxygenating properly when you have circulation like that, right?
No, because your oxygenation depends on your lungs. You may have what we call low cardiac output state where your heart isn't pumping that much blood, but as long as you have a pulse, that's not affecting your oxygenation.
So circulation of blood does not affect oxygenation?
No, the oxygenation is determined at the level of the lungs. Now, when the heart distributes blood, there are certain tissues that may not get enough blood supply and therefore not get enough oxygen in a low flow state. But the priority is the brain and the heart get the blood supply up until the very end when there is no blood flow at all.
And you talked about the excited delirium, right? This idea of excited delirium, right?
Yes.
And you said that that it's been, I don't know what your words were, but disavowed by some of the associations. Is that right?
I may have used the word debunked,
Debunked.
and I also said that it's not accepted as a legitimate cause of death assignment.
Well, what the American College of Emergency Medical Physicians, am I saying that correct?
Yes.
What they said was they're not going to use the term excited delirium anymore, right?
Yes.
They said they're going to use the term agitated delirium, right?
Go ahead. Continue. No, I think in 2009, the American College of Emergency Medicine Physicians came out with a statement in which they endorsed the concept of excited delirium.
Sure. Let me walk you through it.
No, let me finish my answer.
Well, I said, is it?
Well, the question was, do they not use the term agitated delirium?
That was the question.
Okay, so
The question is yes or no.
Do they use the term agitated delirium?
not as a cause of death, no.
Okay, but they still recognize that agitated delirium is a thing, right?
Yes,
And that first responders, including emergency medical physicians, encounter individuals with agitated delirium, right?
yes.
And they still recognize that it can lead to sudden death as well, right?
I believe in their 2023 statement, they said that they no longer endorse it as a cause of death.
Have you seen their 2021 statement?
I looked at the more recent 2023 statement.
Okay, but it starts, their initial comment on it is in 2009, like you said.
Right,
And then
right.
they said, they acknowledge excited delirium,
Right,
Okay, and then they came out in 2021
right.
with a new position, correct?
Yes,
After this incident.
yes.
Okay. And are you aware that the paramedics in this case are trained on excited delirium?
I'm not specifically aware of that, but I don't deny it. Yeah.
Are you aware that there's training in Washington State with officers on excited delirium as well, right?
Yes.
Okay, so it's your position that that's something that's not a thing.
So, that's not my position.
Okay.
My position is that agitated delirium cannot be accepted as a cause of death. The fact that people have agitation, that they can be delirious, of course, we all know that. Everyone has encountered that. And that it can be a contributing factor to create a medical crisis. Yes, we all acknowledge that. But as a cause of death, independent of assessing what has happened with the heart, what has happened with the lungs, what has happened with the EKG, excited delirium is not accepted as some blanket cause of death attribution. That's the key thing.
Last thing, just because I think it's clear as mud right now, which is this idea of Lieutenant Wilson's testimony, right?
Yes,
His testimony, it comes from where you sit right now, from the stand, right?
yes.
Okay. Your reference to his prior interviews with the AGs are not testimony. You agree with me that, right?
So I don't know the legal definition of testimony in that sense.
Okay.
I mean, I don't recall whether there was any swearing or affirmation. I don't recall
Okay.
how you
And-
legally define it.
And counsel showed you the interview with Lieutenant Wilson where he in fact says that there is a pulse, right?
Yes,
And he essentially says, it's in response to questioning from Dr. Clark, actually, right?
yes,
Okay. And Dr. Clark is saying, well, I want to present this idea to you about what I think happened, right?
yes,
Okay. And in response to that, Lieutenant Wilson says, listen, I'm trying to save this guy's life, right?
yes,
And I'm not sitting there looking at the EKG monitor, having my finger on his carotid or on his pulse and looking at it and telling you when I can see PEA and when I can't, right?
yes,
Okay. That's what he said in the interview.
right,
And then when you look at the actual pre-hospital care report, right?
yes,
It indicates when CPR actually started.
yes,
Okay. And that's at 11:41 about.
yes,
Right? And we know that you initially said you thought that the PEA was at 11:37:32.
yes.
Okay. And you now acknowledge that that's not PEA, right?
If in fact there was no pulse, then yes.
Further direct.
No questions. Thank you.
Mr. Purcher?
No more questions, thank you, Judge.
Mr. Esser? Okay, Doctor, thank you very much.
Thank you, Your Honor. Leave these here, right? Okay.
Yeah, go ahead
Yeah,
and leave that.
there are
one.
two exhibits there. Well, let me see. This is mine, this is mine, this is mine, and this is mine. Those are two exhibits, yeah. Thank you. Thank you.
Okay, ladies and gentlemen of the jury, you're not aware of this, but I told counsel yesterday that I was going to have to stop our proceedings a little bit before noon today because I'm chair of a committee and we're having a meeting and I've got to attend the meeting and so on, and I need to leave to do that. Or actually, we're going to have it on Zoom here in this courtroom. So I needed to excuse everybody a bit early. It's now like 10 minutes before noon. I think it's kind of a silly thing to bring somebody in, swear them in, and stop already. So we'll do that hopefully at 1:30 when we resume our trial here. So we're leaving a little bit early today, but that's the reason why. So with that, please do not discuss case among yourselves with anyone else, and do not permit anyone to discuss case with you or